So we're going to have a great and most interesting talk today on research in mindfulness-based programs. And I'm really looking forward to this. Diane, thanks so much for coming. Great to know.
So I'm going to go over with you and present to you the research I'm currently funding in, but I'm going to do it with a historical approach to tell you how I got there, and also to share with you some of my findings that have come along the way, sort of in the process evaluation, which I think is really very informative, and a little bit of the outcomes that are starting to come out from this study. I'm waiting for my slides to come up, but you know this stuff by heart, so really I could keep going. The research I'm doing is on bringing mindful-based parenting. I created a mindful-based parenting program specifically for women who are in opioid treatment, pregnant women and new moms. But the reason that I came to mindfulness is through prior research, which is also combined with this. So this research is kind of kooky. I don't quite understand why they funded me for this research, because it's two different. I came up with a plan where I integrated. I'm going to do pediatric practice transformation, and I'm going to do mindfulness with parents who are opioid addicted. And I think you should fund me for this because I think we're going to get some great child outcomes. So I must have said it in a way that convinced them. So that's what I'm going to talk about. But first I'm going to, because I don't know what you know, okay, let me do this. I'm out of this. How do I get out of that? Sarah, do you know? I just want to go to the next slide. And I don't want to do that every time. Yes, yeah. Okay. Good. Yeah. Okay. So really, what this kind of lays out to you is a slide from the CDC and DHHS about ACEs in our country. And I want to spend a little time about ACEs. It's kind of a hot topic. People are talking about adverse childhood exposures today. Everyone is talking about it. Nemours is planning on, probably writing a big grant, and HPS is interested in it. The whole city of Philadelphia has an ACE task force. There's a national movement to recognize adverse childhood experiences because we really know how it impacts health. But just sort of thinking about all of you who may be clinicians, when you see patients, that 1 in 4 are walking in who have had physical abuse. So you have 4 patients, one of them has suffered physical abuse in a severe traumatic way as a child. If you look at sexual abuse, this is really high and a very quiet statistic in our country, but it's 1 in 5 children, people who are adults now, has suffered some form of sexual abuse during their childhood. Another statistic, and one that I'm drawing my research towards, is this household substance abuse. And when you look at that, 27% of all of the folks that you see and we see population-wise have grown up with substance abuse in the home. So this is important information. If we look, and then when we think about ACEs, adverse childhood exposures, the majority of funding happens after. There's really little to no funding. I have it, but that's brand new. But the majority of funding historically has been after the social, emotional, and cognitive impairments actually began. Say, kids in school who already they're developmentally delayed, emotionally, cognitively, and they're emotionally having emotional problems and acting out in school. Or the other big chunk of money in terms of our funding goes to chronic disease, and chronic disease is directly related to ACEs. So it's emotional, mental problems, drug abuse, alcohol abuse, all of these are, and Folletti, who determined ACEs, or came up with the term and did the initial research, said it's actually responsible for obesity, or a big contributing factor to obesity in our country as well. So when you look at what we were doing, me and my team, it was Steve Carey's, who's the chairman of pediatrics at Jersey Shore University Hospital, and he's also the director of the Twin Network for the AAP, that's the Quality Improvement Network. And he and I started working together in about 2001 and came up with the idea that in order to stop these ACEs, we needed to come up with an intervention, so we created Practicing Safety. And the basic premise of that was we were going to take modules and implement them with pediatric practices to see if we could prevent abuse and neglect. And our first feasibility study was, could we get a practice to actually agree to do this? So, and you can imagine that 15 years of my research has been figuring out how do we get practices to transform, because it's not easy. We were fortunate, Ben Crabtree, Kirk Stange out of Case Western, Bill Miller, were doing this work prior to us, national level with family medicine, and they took us under their wing and they said, hey guys, if you want to spread this to pediatrics, we would be happy to mentor you. And they mentored us, and we were able to get over probably 8 years of funding from the Doris Duke Foundation through the AAP to actually move this complexity science, transforming primary care pediatric practices, but doing it in a very different way. So what's different about ours is really it's a radical change of looking at it. It's so radical that even my colleagues at Nemours have not welcomed me into the fold yet on this, and they will, I think, at one point or another, because we've been successful. But it's really because it's anthropological. And what is that doing in medicine? There are a small core group of people who believe that there's room for medical anthropology, but typically not in terms of the people who decide how we need to increase our revenue. So they're in a different kind of camp. So what we do is we look at the culture of the practice, and we study the culture of the practice, and we look at them and we learn about them. And there's a couple of papers that have been published by me and my team on this. And once we understand the culture, then we ask them if they could adapt what we would give them, the tools. How would this be? And we do that with a QI consultant. And we really continue to work with them around the challenges. So the challenges don't become something that we come back to the research meeting and say, oh, we got it really, sort of got stuck today. No, what we do, every challenge is seen as another opportunity to really help the practice change. And once we started treating them as they should have the control, and they should determine, is it these modules that they want to put into place, and what else do they think needed? So, for instance, in the early years, docs would say our telephone system is really horrible. So work with us to help us figure out how to have a good telephone system, and then we'll adopt your modules. So we would be like, yeah, that's our, we got to throw some money in the pot if we're going to work with practices. Today it's very different because the majority of practices are owned by systems. So it's really, how do we then go to change these practices? And the ARC has been watching our work for this 15 years, and so if you wanted to read more details about it, they actually do a historical, very brief, but chart the history of this research in their Innovators website. Goes along with today's talk. And the first paper that we wrote, we bring this up because post hoc analyses is really, and post hoc findings are really some of the most important findings we have, because we're not, all researchers, we kind of think we're extremely bright and we know what we're doing, but we're in the world of the human messiness. And so when you're doing behavioral research, often your hypotheses, sound really well-founded, are not really going to be the most interesting findings. And it was in this study. One of the most interesting findings was I did in-depth interviews with all the physicians who went through this study, the lead physicians. And at the end, I took notes and I asked them very specific questions, and I listened to comments they had to say. physicians have a lot of interesting information, and more than that, they have a lot of big opinions, so I wanted to kind of capture that. But one of the things that came out when I got the data was that the physicians who were really successful in implementing practicing safety all had used one of two words, either mindful or reflective. And I just didn't know what to do with that, because I thought that, were they that coming in, we didn't do a baseline, or is that just what happened? And when we went back to talk to the practices, they said, no, the process made me reflective, made me mindful. So I went back to Kurt Stange at Case Western. I said, Kurt, here's an interesting thing. And he said, yeah, Diane, just create an intervention now that increases mindfulness in physicians, and I think you'll be on your way. I said, okay, thanks, really, Kurt, for that great advice. So that was our finding from there, and it really stayed very, very close to my heart, wondering what we could do about the mindfulness. So I want to talk a little bit about what mindfulness is, and to let you know, I'm implementing a new module in the practice to talk to staff want to learn what mindfulness is. Physicians are not so interested yet, but once they see how happy the staff is, I'm thinking we'll get them in eventually. Because you just can imagine how can they fit one more thing in there, right? And that we'll talk about cup size in a bit. But really, what is mindfulness? So it's the ability to stay present. What Kabat-Zinn says, and John Kabat-Zinn is the founder of mindfulness. He did this at UMass Med School over 30 years ago. John and Saki are two of my teachers, and I've been trained by them, as well as Diane Reibel, who is one of their first graduates of the first 36 they graduated. And Diane Reibel at Jefferson is an amazing find, just to say that we have probably the second best mindfulness program in the country at Jefferson because of Diane Reibel's work there. John says it's paying attention in a particular way, on purpose, in the present moment, non-judgmentally. So let me ask you just to do this. Whatever you're doing, if you're eating, do it with your teeth. I'm going to ask you just if you would just pick an object up. We're going to do a 1-minute exercise. Pick whatever object you want to pick up. And now, I'm going to ask you, just first, let's take 3 deep breaths. It just feels good to inhale through your nose and exhale through your mouth. And if you can make a little noise with that or a sound, it'll even be better. So do that with me. I know. Okay, now that you've done that, you've got an object. I'm going to ask you to just look at that object and just follow me for a few seconds. So as you're looking at that object, can you put your complete attention on that object? And just think about that object for a moment. Other thoughts might come in. You're just going to let them go. Back to the object. And looking at the object, you may want to turn it over. You may want to look at it closely. And just keep bringing your attention back to that object. Okay, and now I'm going to ask you to come back and pay attention to me. So one of the things, anybody have any thoughts, any popcorning of any words that you might have experienced while you did this? Any sense?
Imperfections. Imperfections.
You saw imperfections. Okay. Centered. So Dominique got into, and I love Dominique, and she's one of my academic children. So Dominique got into a little bit of judging and using, because she's very bright. She goes to her head first, and so she was judging. The person behind her said, centering?
Centered.
You felt that centered. Anyone else happen to feel centered or grounded?
Connection.
I couldn't hear you.
Connection.
You felt your connection. Yeah, that's another. So those are the type of things that you get. We did a 30-second mindfulness. I have to tell you that at place in my career, I sit for minimum 20 to 25 minutes in the morning doing almost this with a couple of other things, but really sitting and doing this mindfulness. And the reason that we talk about this as being so important is that this allows us to understand the ability to respond versus reacting the more we do this. So you felt centered, it was very quick for you, and you felt a connection, it was very quick for you. Some of us, for me, it took a lot longer to even come to those kinds of terms and understand that. But it has a way of helping you, and I'm going to do a little bit more explanation of what else mindfulness is. So if we talk about mindfulness in terms of pediatrics, and this comes from Stanford, these are some of their mindfulness slides. It helps focus and helps more clarity. So that the exercise that a lot of people do is something called the raisin. They eat a raisin and they with their eyes closed, and it takes them about 7 to 10 minutes to eat this raisin, and they have a whole different experience of raisin. But the other part of this too is, like, say you look at the fork. It's really interesting to think about, where did the fork come from? What are the materials? Who made it? Who did the hard work? Did a laborer pick? A laborer go and actually work in a factory, and for how much money? So what gets us what we consume? And that's another good aspect of mindfulness. It's not about guilt, and that's not where we're going. It's about just being conscious of what we have in front of us, and having us be more open-minded and have more ability to think. So in terms of physicians and staff, people who do mindfulness, and the great example for me is I asked Sandy Hassing, who most of you probably know, president of the AAP. I said to Sandy a couple of years ago, do me a favor, take the mindful-based stress reduction with Diane J, because I teach it. And she said, why? I said, I think it's good for physicians, but if you do it, I had a funny feeling that Sandy was going to be an incredible leader, so I really wanted to explore it with her. And what she actually helped me figure this out is that she says that it actually expands her ability in the clinical encounter by doing mindfulness and being grounded. So one of the things we do is we say with the physicians is, and all clinicians, when you leave one room, patient room, and you have your hand on the doorknob, that'll be your signal that you're leaving that patient behind. Because very often what we do with clinicians, what we do as clinicians is, we go into the next room, we still have that other patient in our mind, or the patient's family, and we're thinking while we're trying to listen, and we're really not there with that patient. So there's a worry. Physicians do a lot of worrying, and so self-compassion is really important, I think, for physicians and for clinicians in general. But the truth of the matter is, worry does not keep something in our cognitive mind. No matter how much you worry, you think that if you worry enough, you'll be able to solve it or you won't forget it. But the data's in, and it shows that worry just takes up extra brain space. It takes memory. It's taking space that you don't need. And it's really something that we, link to fear. We get a lot of reinforcement in our society for this, but we really have to find new ways of letting this go. Because in terms of, just imagine you're a clinician, and some of you are, you're a clinician, and what does your organization do is figure out how you can do more. Or they don't really figure it out, they really just say you have to do more. And so you have to do more, and you have this cup, and this cup is really full. Meditation, mindfulness, and even yoga to a certain extent expands that cup. Because if you can be present, you can do more in less time, and that's some of the research that John and Saki have done. It also means that if you can have a better well-being, feel better about yourself, and sleep better. Before I did mindfulness, I was a very fitful sleeper. I woke up in the night. I had 5 children, so that really kind of trained me to be up to every little sound, right? But after I started meditating, what I found was my sleep was deeper. But really the issue was I was not worrying as much. I still worry. I'm a worrier. I come from a worrier family, warrior culture. We're Sicilian. We worry and we fight. We don't really spend much time in the area of joy. But I am seeing something fundamentally change within me, and I see it with my friends and my colleagues who are doing this. By the way, my research staff, so we have and I'm going to talk about this grant, we have a $1.8 million grant from the Children's Bureau, DHHS, and one of the things we've done with the funding is every research staff and every investigator has taken mindful-based stress reduction for 8 weeks at Jefferson. And the team is really, really changing. It's nice to see people be happy and not crushed by the work. And so this is it. I put this up because I say to people, if you could just do 10 minutes a day of doing nothing, plain doing nothing. That's what this mindfulness is, sitting there somewhere quiet, watching what thoughts come in, and not, my husband just said recently that he was listening to NPR and there was a mindfulness story on there from England, and the NPR commentator said, well, you know, can you give me a concrete example of mindfulness? And the guy said, yeah, you know, thoughts come by all the time, just don't get on the bus. So that's the kind of thing of sitting and just recognizing that thoughts are coming, they're only thoughts. You don't have to go with them. And really, when feelings come up, really acknowledging those feelings and not pushing them down. Because that's what we usually do. We grab onto the thoughts, we push the feelings down, and then we wonder why we're miserable. We can't diet, we're not exercising enough, we didn't smile at our spouse, we snapped at our children, and we're not nice to our coworkers. One big one too. So all of this, a 10-minute a day, and if you do this, you can email me and let me know. I'd be really happy to hear what happens. So as I said, we applied for this grant, and this grant, so that it's in Delaware too. There's a Delaware, I forget the name, but in Wilmington, Families First is yeah, they have this grant that I have in Philadelphia. Particularly, you could apply for the grant for either working with HIV-infected pregnant women or for women who are childbearing and drug addicted. And so I wrote this grant with Esther Chung, who's a Nemours pediatrician in Philadelphia. She was one of the co-Is I pulled in. Carol Kaltenbach, who is a leader in opioid addiction treatment and just recently retired. And Marnie Lanou, who's also at Jefferson. So I wrote the grant. I got the three of them to agree that this was something that they would do with me. And about 3 years ago, we were awarded this grant. So as I said, the background is practicing safety. It's 3 bundles of tools. And those bundles of tools include attachment and bonding, maternal depression, toilet training, discipline, and there is an EPIC adaptation to this as well. Which once you get it in EPIC, then you can really make sure 85% of folks are doing it. Some people still will be resistant. And then the piece that we're doing in our 4th year, this coming year, is mindfulness for clinicians and staff. So in the Philadelphia Nemours practice, the director of that practice, Bill McNett, and said, if you give my staff mindfulness training for 6 weeks, I'll donate half an hour, and they donate half an hour for lunch, which is kind of a good motivator, because you don't want the people coming in just because they're getting time off from work. So we're going to do it with a small group, and we're actually going to measure what happens in the practice. And that's the last sub-objective of this grant. The other objectives, as I'll show you, are all underway. And then we do mindful-based parenting. And can you imagine what it's like to do mindful-based parenting with women who are on methadone, primarily on methadone? We're going to move, hopefully, to Suboxone in the future, but that comes with its own set of issues. Moms who are on methadone, about 1/3 of whom are using, which is, I think we're probably 20%. I think citywide in Philadelphia, it's 30 to 35% of methadone users use while they're on methadone. So we've talked about this. And so we're doing mindful-based stress reduction with these women. It's in trauma-informed. So that's the other thing about ACEs and why ACEs are important. Because as clinicians, if you don't get that the person you're talking to may have been trauma-informed, you're probably adding to their trauma just because of how busy you are. Because you might say, hold on for a minute, I just have to check, somebody else is on the phone, I'll be with you in a minute, and close the window. And to them, it might be, they're rejecting me because I'm a former drug addict, or I'm not wearing the right clothes, or whatever is tape is in their head. So understanding how to be more trauma informed is key to how we get folks to listen to us. And I think that's one of the reasons we've been really successful with getting these women. They sit 12 weeks, volunteer. They have 5.5 hours of mandatory counseling to get their methadone in my program. And then we have this other 2.5-hour program a week. And they get a little incentives, but it's not big money, it's small. And we get a large number of women. Now we're not even recruiting, now they're coming to us because they're hearing through the grapevine from their other, the other women in the program, that they want to sit there and they want to meditate and they want to learn how to be with their children. And the third piece to this grant is we have comprehensive case managers. And really, pediatricians and family medicines need case managers or health coaches. They need someone who connects into the community. And so we have a social worker in the practice, a case manager in the drug treatment program, and they connect over every patient in the study. Because what we're looking for, one of our outcomes, and I'll explain this more, is that we want to look for, in terms of our outcomes, we want to see if we get improved adherence to well child visits and improved to the immunization schedule and adherence to that. Because these are the mothers that fall off. These are the moms that ruin the statistics in well child care because their lives are so complicated. So we threw in these two with really thinking we're going to do this, and we use our case management system. So what do we want to do? We want to prevent toxic stress. We want to improve, and the reason why I say toxic stress, I'm just going to do a definition here, is abuse and neglect, right, is one thing. Then we have ACEs, we talked about that, adverse childhood exposures, which include abuse and neglect. And why we're saying toxic stress today, we're going with the Harvard people and using toxic stress, is because we know each of these things changes brain development. And if we don't do something different along the way, that brain development continues to adapt, maladapt throughout their lives. So that's toxic stress, is really looking at preventing toxic stress by improving parenting, and I'll talk more about that. And we want to decrease parental stress, not an easy thing to do, and decrease exposure to adverse events for both moms and their babies. And we want more mindful and intentional pediatric practices. So those are our outcomes of our study. And I talked about Mater is Maternal Addictions Treatment, Education, and Research at Jefferson. It's a program 30 years in the making. Finnegan was Dr. Finnegan started it, and she is the...
I worked in that program when I started it out of graduate school. That was my first job.
Yeah. And Dr. Finnegan created the NAS score. So if you're using the Finnegan score, this is the program that she created that score from. Mater is globally recognized. Even Australia has modeled their program on Jefferson's program. I'm only there 7 months, so I'm like, I'm not the creator, but I can brag about this because we're seen as the second or third best program for maternal addiction in the country. UNC is a competing program with us in terms of their work, and Vermont, because who knew that Vermont had the second highest rate of opioid addicted pregnant women after Pennsylvania. We have My Sister's Place. We have, and in terms of our numbers right now, just so you understand the epidemic of opioid addiction in the country, we're a little silent about it, and it is a raging epidemic. We're seeing our census is supposed to be 220 to 225 on outpatient, and about 16 to 18 inpatient. And right now we have 245 in the outpatient. We have 22 women on average with 3 kids in our residential treatment program. And we don't know what we're going to do. We're trying to get licensed to have more because it's just such a growing epidemic. It's like 2 women a week that are coming to us, and some of them fall off treatment, but by and large, if you're pregnant and you seek methadone, you're in it for at least through delivery, because you really have a commitment. If you can keep them through delivery, you got a good chance of keeping them afterwards. So these are, I talked about this, and there are very ambivalent feelings among these mothers with their child. And it's not the ambivalence of having them or not, because they don't have to have these babies. They're usually, for the most part, heroin addicted, find out they're pregnant, they go, the pediatrician, the obstetrician says, you want to get on methadone and it'll be better for your baby, and they say yes, and they do that. During pregnancy, we don't have a lot of multi-use illegal substance, multi-use. It's after pregnancy that we see it creep back in. But these moms are really, when you're around them, you can see that they're really courageous. We kind of have in our heads that they're addicts, but really what they are, they're courageous. And if you think about my whole story about ACEs, what we're talking about in opioid addiction is people with high ACEs who are self-medicating. And self-medicating in a crazy-ass way. No doubt about it. I'm not justifying it, but I'm just saying, can we look at them differently if we, and this is part of the mindfulness piece that John Kabat-Zinn says, is if you can change your perception, do an orthogonal shift on who these people are, you might actually be able to help them. Because if you saw them as somebody who was courageous, who was trying, and they fall off the wagon and use benzos next week, or they shoot up again, and then they come back, and if you could see that as them really wanting to try again, rather than as being somebody who didn't follow the prescriptive treatment, you have a different relationship with them, and they see you as somebody willing to help them. So they're very punitive to themselves. They see everything their babies do after their babies are born. Everything they think is related to them having used opioids. So baby cries in the middle of the night, that's because of me. Baby spits out the food, that's because of me. Everything that the baby does negative, and they see very little positive in their child, because their child is just another stress. And they don't understand, obviously, they don't understand developmental issues. So this is another piece of, in our mindfulness class, is these are the kinds of things we're teaching with the mindfulness, right? What happens, what is a baby like at 2 weeks? How many hours does a baby cry? And meanwhile, in the practice, we're doing the same things, because we have taught the physicians, babies cry 6 hours a day when they're newborns. That's the average. They could go 8 hours. They can be as little as 4. And what do babies do? Babies crying is really natural and part of their development. So changing the whole dynamic there, all around them, so that they're hearing it from their pediatricians, they're hearing it in mindfulness. The other thing that we see with the moms before they come into mindfulness is you can imagine this too. If you have some older adult relatives from different countries or less educated, and I come from a very working class background, so I understand this. But there is this attribution that parents who are not well informed do, which is to say, to a month-old baby, he pushes every button in me just like his father. Or she's miserable and she's got a miserable personality, and just like my sister. So they attribute these newborn babies to having a lot of power in their life because they don't understand this. And walking them away from that is really important if we're going to decrease toxic stress. So attachment is a big piece, and that's one of the things that we've been doing with this, with the mindfulness, and really teaching them how to give up those are thoughts you have about the father and the sister. Those are thoughts. We let the thoughts go. What are the feelings? And we do with the baby, like I asked you to do with an object. So the babies come into the meditation 3 times during the 12 weeks, and the moms actually are asked to look at the baby as if they've never seen the baby, and look from head to toe, and then touch, and then smell, and then listen to their heart. And these women start, even as I tell it, I start to tear up because these women start to cry. And they say things like, I've never seen the baby like this. And then they come back and say, I put the baby on the bed and I just watched her. And they had never done this before. Really building that kind of signaling that we want them to be in tune to, and really starting to develop their own executive functions. So the baby smiles or calls to you. They say, "Oh no! Ever since I've been in mindfulness, my baby's been smiling." You know, and so those are the kinds of things that we see. And looking at the literature, we really know that mother and child, typically there's poor sensitivity, unresponsiveness in this particular population. But there's also been, as I said before, really basic development. These women are not, and I'm going to tell you who these women are, and I think it might surprise you in a bit. But so what, in the past, what's been done with these women in parenting? Well, the only thing that's been done is the mother-toddler program is the only one that has been shown to be significant, statistically significant changes in improving parenting in these women. And but it requires long-term, individual, extensive therapy. It's highly expensive and it's very labor-intensive. And with our economy today and the way we're moving, that kind of thing would not be paid for through their insurance. So mindfulness is mindful-based parenting is an experimental alternative to that. Really focused on this idea of nurturing, attunement, awareness, acceptance, and learning to respond versus react. We have 12 weeks, like we said. We've had 8 cohorts go through this program. They're like 3 times the moms brings the babies in, and they meditate with the babies in there. We're teaching them body scan, which is a really difficult thing for them to get centered in their body. Their bodies are not someplace they want to visit because it brings up a lot of history. The majority of these moms have been either physically abused or have used their body for survival in many ways. So we have that. We have quarterly support groups, and we have a teacher. We have 2 teachers. One excellent teacher from Delaware. She's amazing, Carolee Palmer. If you don't know her, I suggest that she is someone you should talk to. We adapted this, I said, to trauma, because mindfulness was really for a middle-class community. When John Kabat-Zinn created this is for middle-class, educated people. And so how then do we bring it down so that it is meaningful to just the average folks like me? And one of the things that we did was really change the language. We refocused around the things that were sensitive. So in MBSR, typically you do body scan first. That's like one of the first things you do because it's really easy for us to like say, go to your feet, go to your ankles, but not with these women. So we had to move the body scan further in because of what I said, their trauma with their body. We had adapted the breathing. And so the breathing was difficult too. Women felt like they might be in a panic if they started following their breath. So we do something called the glitter jar, and they melt. It happens the first class. They create a jar. They put a little bit of a glitter glue in it, one color. Then they add another color, glitter, not the glitter glue, and this is all in water. And then they add a third. And the first is for their body sensations. The second glitter is for their emotions. And the third is for their thinking. And then after it's all set up really pretty, they pick their 3 colors, they shake it, and then we start to talk to them about this is what you feel like when everything's going crazy. And if you can just breathe, let's see what happens. And so all the glitter starts to settle and the water gets clear, and they will not let go of these glitter jars. They want to make a second or a third. They have one in their big pocketbook, they have one in their diaper bag, there's one at home. Everyone has glitter jars. Now the staff has glitter jars. I have a glitter jar. My grandson uses my glitter jar. It's infectious. So those are the movement was difficult in these women. They're on their way to comorbid conditions. They don't eat well. They're overweight. They don't exercise. They smoke. Heavy smoke is really an issue. That's another little study we have going on right now with University of Penn to see if we can get them on medication and get them off tobacco. And like I said, the curriculum is flexible. We bring in a counselor. We have a counselor and a teacher, so we have somebody clinically in the group. They get encouraging emails during the week personally from their teacher, which keeps them connected, because we needed something to make sure they came back. And it's the personal connection, because they're people like everybody is. And so when the teacher emails them and said, hey, I was thinking about you. Hopefully I'll see you on Tuesday. Please, bring in how you felt this week, and whether mindfulness was something you could reach without judgment, that kind of thing. So what do our statistics look like? In terms of the practice, you can see here in this slide, assess crying. We went in and the practice wasn't assessing crying at pre, which is at that point. And now this was month 7 and 8. So now we're at month 16, but we're holding. The pattern hasn't changed. So there's real improvement with the practice to assess crime, which means that what do you think we stop when we prevent, right? What do we prevent? Huh?
Child abuse.
Yeah, what kind? What is it? Yeah, right. So that's one of the reasons why that we do this. And resources for parents are climbing too, that they actually give them resources. Screening for maternal depression. It went up and down originally. It's hovering right now. I would say right about 60 to 70. We were 60 here, and this was before all the module tools were in EPIC. We're actually moving above that. Resources, temper tantrums, almost everything went up. Anticipatory guidance and resources kind of goes up and down for tantrums. Tantrums are one of the things we find the physicians, if there's a lot going on in the visit, they may not get to that. We understand that. And here's the one I love. This is NHPS helped me. And she's sitting right in the room. Came and trained by docs on developmental screening. I could not get them to agree to do developmental screening. And then I said, well, Nemours has it, and Nemours wants you to use it. There are Nemours practices. I said, okay, bring it in. We had great folks from NHPS come in and train them and look at where we are in developmental screening. And it's kind of interesting because the practice actually made money on the developmental screening, and the docs didn't have to do it. So in the first quarter, they found they made $25,000, and not all the physicians were doing it, less than half. They project now, if not all the physicians do it, but just moving the direction they do, they'll probably make about $125,000 in revenue in terms, and with very little extra work, because they already have a social worker. So it's the social worker who's going to address getting the resources for the child that shows a developmental delay, and it's the staff who does the peds with them. Some docs like to be involved with that, and we encourage it. But that's really, really important. And like I said, Kids Health, we're working with Kids Health now to help us with get our resources into their system and use their resources. And EPIC, so that's really great. In terms of case management, what we found is the case manager, the social worker, meeting the practice, and the case manager follows up with every mom. And then what we like to do is get the case manager to give the social worker just a few little lines to put in the EPIC. So when the doc sees the patient, the family the next time, he could see that, or she could see that follow-up occurred and something's happening. Because one of the big issues, right, with trying to get physicians to do these, the new morbidities, to address the new morbidities, if they don't have the tools. They don't want to ask a question and then what do? Go home and think, well, this family's hungry. What am I going to do with this? So really giving them, making sure that they understand that the resources are being given to these families, and it's a nice way to close the loop, and it gets them more involved in these new morbidities. These are the kind of thing some of the things we look at in case management. We're looking at domestic violence, child abuse, all the things that you would think. And our largest issue is housing. As you can imagine, we're a country that's really divided in terms of wealth, and we're seeing it in this population. And it's kind of shocking that it would be in this population, because you would think this population would have more support. the average age of the women going through the mindfulness, which is similar to the women in drug treatment, both in Philadelphia and nationally, these women are 30 years old in treatment. They have on average 2.5 children. In our program, the range is 1 to 10. We have several mothers who are under 30 with 7, 8, 9, or 10 children. Number of times pregnant, the mean in this is 4 times pregnant. These are white women, primarily white. They primarily have some college to college education, and they're unemployed. They come from the suburbs, because this is the opioid epidemic today. The opioid epidemic is not what it used to be in this country. It wasn't an epidemic then, but now that it's an epidemic, these are the women. They're college. They're Catholic. They're Catholic girls. They're primarily about 70%. That's their religion that they grew up with. About half of them receive WIC, and 87% receive SNAP. They're primarily in relationships, but they're only 8% are married. And we're doing the numbers right now. They're in relationships, but not necessarily with the father of the baby, which is that's pretty typical too. And then is their partner using illegal drugs? And this is an underestimate. About 30% are currently using drugs in the home. Typically, in our world, people get to take home their methadone after they meet a certain level. It's unfortunate, but babies get a hold of methadone, and children die in these programs from methadone. And across the country, I'm talking about, this really happens. We have, in our study, we have a lot of instruments. We're looking at ACEs, we're looking at depression, stress, and basically what we find, I don't know what's going on. This is physical violence. These are ACEs going across, witnessing violence, physical violence, and physical abuse, psychological abuse. They're high in our population. I'll give you a comparison. This is the number of ACEs. 20% of our population have 5 or more. We know that if you have between 5 and 6 ACEs, where we would normally live to 80 years old, you're going to live to 60. That's the statistic right now. 5 or more ACEs reduces 20 years off of your life. That's Folletti's work and others of him. But look at 5. Can you imagine what it's like to have 5? And here's what we look like, our population looks like. So if you look at this, the ACEs study nationally is the first bar. The second bar is Philadelphia, because Philadelphia is measuring ACEs throughout the city. And the third is ours. So 0, we're the lowest at 17%. There it shows that nationally it's 36% of the population in the country. And then as you continue to look at it, 4 more ACEs. The ACEs study nationally says there's about 12%. There's a new study that says it's probably more like 14. And then 21 or 22% in the city of Philadelphia. And then our population, 4 or more, is 43. So you can really see the impact. And I gave you that before. And depression is about 13% of our women have severe depression. So it's about 20% that have depression in this population. And then stress, looking at stress, pre to post. We're hoping that as our numbers grow, we're about 55 in our sample right now, and we're seeing we're hoping to see that the stress reach significance. We're not quite there yet. Over that, what KIPS is. The main outcome of our study, as I said, was we want to improve parenting. So we use Keys to Interactive Parenting. It's a validated, reliable tool that's used by most programs that are funded like mine from the federal government. They kind of suggest that you use KIPS. It's an observational assessment, and it's done by 2 different reviewers to look at parenting. And what we found in this so far, and this is when we had 40, we're now at 55, and our data even looks better, is we've got mindfulness has shown that parents who go through mindfulness go from low quality parenting to moderate versus our controls. So we're seeing an improvement in 12 weeks of working with them, which is significant because this is a hard assessment to change. Most of the programs in the country are asked to use this, but don't have the results that we're having with this. So we're seeing a positive change. In summary about this population, like I said, has low parenting quality. Just trying to get them to the point where and one of the moms, this is a little story, one of the moms shared with me on graduation day from, we do big graduation. She said that she pulled into the parking lot to come into, to get her methadone, then to go to a quick counseling session, then to come to the mindfulness graduation. She pulled in, she had 2 kids in the back seat, she was pulling into a space, some guy cut her off, took the space. She said in the past, her reaction to this would have been to get out of the car and jump in his face. And it would not have been unusual for her to throw a punch. The cops have been called by other people because this is her reactivity. She said, and the guy pulled in, she got furious, and then she thought, uh-oh, she looked in the mirror, she saw the 2 kids. She said, I think somebody would tell me to take a breath right now. I know somebody, and she did that. She found another parking space, and she took her 2 kids out. She's kind of a masculine woman. She took her 2 kids out, and she's just looking at them and feeling really grateful, and this guy walks up to her. And he said, hey, I cut you off, and I took your space. And I'm really sorry. I feel so bad about what I did. And she said she was like a blithering idiot in the parking lot. No one had ever apologized to her in her life. She had never had a person say to her, I'm sorry. And she couldn't even talk back to them. She wanted to tell them, hey, you're the first person, so she said that these are the kinds of things, these are the kinds of stories that they end up telling. It's like they enter our world with this. We see this, we get thanked. I mean, not as much as we want to be thanked, but we do. So looking at that, those kind of stories and looking at the data, we're in cohort 9 and 10, we have 15 women in cohort 10. 15 women from our residential and from, and it's totally voluntary, they're not really, and they drop out a lot. About 50, we find, well, earlier, but now it's about 65% of the women go through. About 20% who drop out come the next class or the next session, they re-sign up. So it's about, we're thinking like we're right around 80% of graduates